Good afternoon, everybody. Welcome to the first official EMSC Telehealth Advisory Council. And again, if you can please mute your phone when you're not speaking, and we will kick this off. All right, so then if possible, if you can please change your name to include your organization and turn on your video. We'd love to see your smiling faces. And then of course you can share a quick hello in the chat box if you'd like. This session is being recorded and it will be provided on the website below. So I will send that out if you all want to see it or have people that need to see it that weren't able to attend today. Acknowledgements and disclaimer. So this EMS for Children Innovation and Improvement Center is supported by HRSA of the U.S. Department of Health and Human Services as part of an award totaling $3 million with 0% financed with non-governmental sources. And then the contents are those of the author and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. So here is today's agenda. Obviously, we're going to do a quick welcome. I have a couple of informational updates regarding the collaborative, what else we're working on at the moment, and applicant updates. And talk about the advisory council, its deliverables, and the specific focus areas. And then Dr. Macias will lead us in level setting for this meeting. And then we are actually having 3 presenters today on their past or current efforts. We have Laura Ludwig, Dr. Michelle Macy, and Dr. Christina Higa presenting today, respectively the Critical Crossroads Toolkit, the Sprout Questionnaire, and the Telehealth Resource Centers. And then the big chunk of the presentation today will be the breakout session. We'll break out into 3 separate groups based on telehealth, children and youth and special healthcare needs, and behavioral health emergencies. And then we'll do a quick wrap up and have an end of presentation survey. If you could all stay and fill that out, that would be helpful. So as of now, the applications are open. Those opened on September 15th and are open through the end of the month. As of now, we have 2 partial applicants that have started filling out the paperwork, and then we have 7 or 8 other additional states and territories. So as of now, we have Utah, Kansas, Pennsylvania, Illinois, Arizona, Vermont, and Oregon, all interested in joining. Another thing the EMSC EIIC team is working on is a welcome packet for the states and territories that we will have selected by then. And that will include the directory, of course, with all of your information and name, key resources, an activity calendar, activity guide, the evaluation metrics that we decide on, and then the environmental scale. And just as a reminder, the smart aim of this telehealth collaborative is that by June 30th of next year, 100% of the participating states and territories will increase by 25% the number of pediatric healthcare providers who are ready and able to provide emergency telehealth services for the target populations. And then lastly, some informational updates. So we have to review and score the applications once those come in. Obviously, we don't know the final count yet, but those applications and reviews will be due on the 12th of November. And we are expecting all of you to help review those applications. Obviously, based on the workload, depending on how many applicants we get, we will divvy that up. But if there is absolutely no way, that just email me, the email provided right there, and just let me know that you are opting out of the review process. And not a problem, we will make it work. But those of you who are able to help, we will have to have our final decisions by the 16th. We have a selection committee that will be choosing the final applicants on the 16th of November from 1:30 to 3 o'clock that day. And as it pertains to this advisory council, these are the 3 main deliverables that we have over the next 7, 8, 9 months. So number 1, first and foremost, will be the environmental scan. We'll be starting the basis of that today and November's meeting. And then we also need to construct an EMSC telehealth toolkit and provide an EMSC telehealth program performance metrics. But again, those 2 are not the focus of these first 2, or at least this very first advisory council meeting. And next off, I will pass it over to Dr. Macias to level set for us.
All right, so our conversations around quality improvement collaboratives, just as a reminder, are really all about an all teach, all learn environment. Truly not meant to be prescriptive, but really to focus in on what we can gain from the learning that we can get from each other. The construct of quality improvement collaboratives hit upon key areas that are really critical to improving outcomes. And those are a comprehensive approach to data and analytics, how we share common data across different entities within the collaborative. A central project management, such as you see here within this collaborative and with this team, an evidence-based practice approach to the work that we do, as we will discuss today within each of our buckets or domains of work groups, a quality improvement foundation, which is really critical to our ability to rapidly uptake that information, that best evidence, and apply it to our populations. And a research component, not research for the sake of tacit knowledge, but really research for the sake of disseminating our best practices. So in the next slide, as we apply that to probably what is the most common model for improvement visualization, we really go through 3 stages before we reach a plan, do, study, act cycle. We ask the question, what are we trying to accomplish? Those are our specific aims. We ask ourselves, how will we know if a change is an improvement? Those are the measures that we utilize to define that. And then what change can we make that will result in an improvement? And those are the interventions. Those are clustered by key drivers, and those lead us into the plan, do, study, act cycle. The purpose of today's meeting ultimately, let me back up. The purpose of the collaborative is ultimately to push out quality improvement strategies back to the entities, the units that will be uptaking all of these best practices and information to get to better processes and better outcomes. But we're not ready to jump right into the end yet. Today's purpose is really to break up into these groups and parallel to this work that we'll be taking through quality improvement to use this modified approach to quality improvement, which is the focus framework that has been described by HCA as a twist to the model for improvement. And what it defines as focus is finding a process to improve, organizing a team that knows the process, clarifying the current process, understanding the process and the causes of variation, and selecting the process for improvement. So what are the distinctions between what you see on the left and what you see on the right? What you see on the left is what leads up to the plan, do, study, act cycle, which is very similar to the plan, do, check, where check is study. But prior to those steps, there's a broader group that's brought together that at the collaborative level is really defining the process to improve, organizing the teams to create that structure for improvement, and then clarifying the current knowledge. It's really creating an environmental scan that's at the level of a national collaborative that eventually would be taken down to the level or model that you see on the left. So it's a twist to the framework, but the reason for calling that out is that we want to be attentive that our focus today is really looking at those first 3 steps of the focus process. Understanding that we're not ready to measure because we're still trying to identify what are the critical questions to each of these workflows that we want to understand. We want to understand the landscape, and we want to avoid the temptation to jump to the solutions without really fully developing the questions that we're asking. So with that being said, I will turn that back over to you, John.
Dr. Remick, did you want to speak on this, the past and current efforts?
Absolutely. So thanks so much for sharing that background. Charles, I think it's really helpful just to kind of understand this whole framework. Really fast, before we move into the next section, I just wanted to quickly address one of the comments in the chat box, which is related to conflicts of interest moving forward. So as we discussed last time during the orientation session, we would love for each of you to be engaged in the selection committee in terms of those applicants that do join our collaborative. We realize, however, that some of you may have relationships with a particular state or individuals who may be applying. And if that's the case, we're asking that you recuse yourself from evaluating any of those applications. Additionally, our plan is to normalize the scores across all reviewers so that if you recuse yourself from one or two, we'll still be able to normalize your scores across the board. In terms of the work of the Advisory Council, true to what Dr. Macias just shared, is that this is really intended to be a collaborative effort. We realize that there are other funding opportunities that have been developed or underway, either been funded through similar streams or through the CARES Act or other mechanisms, and you may very well be involved in those. And our hope is that jointly we accomplish more together than we would individually, and that the work that we're doing to create resources and tools and advisement for these states is that we're all doing it for the good of the children who we hope these telehealth programs will serve. So I don't know if that answers your question fully, Sabra, but if you have any specific conflicts of interest that you feel need to be shared or that would make it problematic for you to participate in the Advisory Council in any way, we ask that you reach out to us individually so we can address that. So moving forward, we're really excited to share some past and current efforts that are underway, and we're so grateful to all of you for your time and expertise relative to the specific populations we're trying to address, children and youth with special healthcare needs, as well as children with behavioral health emergencies, and also for your expertise relative to telehealth. Over the coming months, as we come together, we will be reaching out to several individuals at a time to ask if you can share a little bit more about your work so that we as a whole can better understand some of the resources and tools that already exist and how we might be able to transform this entire space to really directly impact the specific populations that we're targeting. So I'm just going to go ahead and introduce each of our three speakers today all at once, and then we'll move through. So the first is Laura Ludwig, who's a public health analyst within the Division of Child, Adolescent, and Family Health at the Health Resources and Services Administration. Over the last several years, she's been focusing on mental and behavioral health issues related to cultural humility and health equity, and has led a really transformative project, which is the Critical Crossroads project and the development of a toolkit. And in doing so, she was able to bring together multiple other federal agencies and national professional leaders to help develop that. So excited to hear more about Critical Crossroads today. The other person that we're excited to hear from is Dr. Michelle Macy. She is a pediatric emergency medicine physician and health services researcher at Northwestern University Feinberg School of Medicine. And there she co-leads the telehealth program at Lurie Children's. She's also been involved as one of the core working group members of SPROUT, which is the Supporting Pediatric Research on Outcomes and Utilization of Telehealth. And her primary focus has been really in developing measures for quality improvement work. And then the last is Dr. Christina Higa, who is the Associate Director of the Telecommunications and Social Informatics Research Program at University of Hawaii and co-director of the Pacific Basin Telehealth Resource Center. And for those of you who may be less familiar with the National Consortium of Telehealth Resource Centers, she's going to be sharing with us a little bit more about the work that they have underway and how that might align with our efforts. So with that, I will hand it over to Laura to give us a little bit of information about the Critical Crossroads program.
Thanks, Kate. Very happy to be looking forward to speaking a little bit more about the Critical Crossroads Pediatric Mental Health Care in the Emergency Department project that HRSA EMSC led alongside the Federal Office of Rural Health Policy. Next slide, please. So recognizing the substantial challenges posed by mental and behavioral health issues in this country, in 2017, HRSA launched an agency-wide effort to identify innovative and collaborative strategies to address the public health issue in new, impactful ways. And so this prompted a collaboration led by HRSA, Maternal Child Health, Emergency Medical Services for Children program in partnership with the Federal Office of Rural Health Policy, examining pediatric psychiatric emergencies, which we know constitute a large and growing segment of pediatric emergency medical care needs. I know Dr. Remick highlighted in our last meeting some of these statistics, but over a 10-year period, we've seen a 60% increase in pediatric behavioral health visits to the emergency department, and specifically a 330% increase for suicide self-harm. We know that suicide is the second leading cause of death for children and adolescents 10 to 19 years old. And the emergency care system is increasingly becoming and has been the safety net for a fragmented mental health infrastructure, in which we know that children and adolescents are among the most vulnerable populations. I'm sorry, you can slide back. Sorry about that. EDs are seeing an increasing number of children and adolescents in mental health crisis. And however, the emergency medical services system is often not adequately prepared to manage these patients. So many children are not receiving the needed so what does that mean? That many children are not receiving the needed comprehensive treatment for pediatric mental health visits and are often discharged from the emergency department without guided referrals for behavioral health specific follow-up care. And so with a collective national shortage of pediatric behavioral health specialists, we also know this is disproportionately impacting rural, remote, and tribal communities where resources are limited. And amidst the current crisis, we know that economic downturns are associated with increased mental health concerns for children. There's been a loss of access to services, distress directly related to the pandemic, of physical and social isolation, changes in school environment, increased screen time. And we know this disproportionately impacts children and families with existing conditions, underserved communities, and communities of color. In late 2017, we launched the Critical Crossroads Project, improving emergency medical services for children in mental behavioral health crisis project, with the expected outcomes that you see there on this very wordy slide. So our first outcome was aimed to strengthen the federal partnerships and stakeholder engagement around this issue. We engaged a federal steering committee with representatives from over 10 federal agencies across HHS, the Department of Transportation, and the Department of Justice. We convene monthly, and we engaged a panel of subject matter experts who represented various national organizations across the field to contribute to this work. So the very tangible product of this collaboration was the creation of a tool which aimed to disseminate the available resources. And that tool is the Critical Crossroads Care Pathway Toolkit, which contains a template that's designed to help hospitals establish a customized care pathway, which can be adapted to the resources available in that community to support the identification, coordination, and continuity of care for children presenting to emergency departments with behavioral health needs. Next slide. So here on the slide, you can see kind of the framework for the tool. To develop this tool, we conducted a targeted literature search of the scholarly and gray literature, an environmental scan, and went through various iterations with a subject expert panel review process. And we distilled the resources into our developed template care pathway algorithm, which you see here on the screen, which you could probably barely see on the screen. And so again, like I said, this reflects the overall organization of the tool, and the toolkit walks the user through the existing resources, literature, and tools that with each respective element of the care pathway to support the creation of, again, an adaptable, customizable care pathway, which can be adjusted as appropriate to an individual facility and the available community resources. So particularly relevant to this group, while we were distilling the resources that we found, cross-cutting transcendent resources opportunities for telehealth, whether that be for connecting to pediatric behavioral health specialists to conduct screenings, assessments, acute intervention, safety planning, or for opportunities and linkages to follow-up care. It was a resource that was cross-cutting throughout the entire care pathway for opportunity. Next slide. And so if you haven't already been able to see that or are not familiar with the toolkit itself, you can access it here at hrsa.gov/critical-crossroads. It was published just in July of 2019. Next slide. So some of the key takeaways from this project has been that the current emergency pediatric behavioral health crisis is an unmet need. We began this project looking at the emergency care continuum, pre-hospital and hospital, that is. However, the tool has been made to be emergency department specific due to the findings of our literature search and environmental scan, and the very limited amount of information we found in the pre-hospital EMS space. Because of that limited information, we made it an ED focused toolkit. And so the gaps in research and evidence, particularly in the pre-hospital space, but really across the entire continuum, are really evident. We do know that many pre-hospital programs are being implemented across the country for individuals in behavioral health crisis, which includes successful models of crisis intervention and diversion, where care is provided on scene or direct transport to like a behavioral health facility is provided, or where telehealth is leveraged in ambulance in the field. And community integrative health or paramedicine models, emergency hotlines, and emergency mental health crisis teams are among those programs too. Another key takeaway is the disproportionate impact this is having in rural, frontier, and native communities, which are often with limited resources. And there's more work to be done in examining EMS, the emergency medical services system, and the full continuum within the broader continuum of care for children in mental health crisis. So where does the EMS system sit within the whole, and how can we improve the system, and how does that impact the whole, and how does the whole impact, you know, our scope within the EMS system? So more thought and foresight into that is also an important component of this improving behavioral health care for children moving forward. And if I could add one more bullet, it would be the opportunity for telehealth that exists here to increase access to behavioral specialty care and potential for follow-up care. So next slide. In a nutshell, that's pretty much the Critical Crossroads project. I'm happy to answer any questions if we have time. Thanks, Kate.
Thanks so much, Laura. And just for the sake of time, because I know we're trying to move forward quickly, if there are any questions, you're welcome to reach out to Laura directly or to put them in the chat box. And she will be in the behavioral health breakout group. So there'll be a lot more discussion about Critical Crossroads and that tool. So Dr. Macy.
Thanks, Kate. I'm here on behalf of the team that I've been working with in the Sprout Metrics Topic Working Group. Sprout's really keen on acronyms that relate to things that come out of the ground. So these are called twigs. And with John Cho, Carrie Galley, Dave McSwain, Donna Shinazi, and Scott Lorch, we've worked on some key questions that we wanted to share with the group today. And then later on, we'll talk a little bit about the measurement framework. Next slide. As telehealth really rapidly expanded in March of this year, we recognized that this was an important opportunity for us to try to put forward to groups some key structure around how they might think about the launch of these programs in rapidly moving times, and really ensure that we're capturing information as things evolve very quickly. And so we put this out on the Sprout website and went through the who, what, where, when, why, and how of telehealth service offerings. And so having people begin with thinking about who's offering a telehealth service. Is that coming from a health system, a health plan, a private company, or a mix of those? Who's providing the specific services? Is it a nurse, physician, advanced practice nurses or physician assistants, pharmacists, public health professionals? Looking at what modalities are being used. Is the telehealth service delivery model live video? Is there asynchronous communication? Is there reliance on remote monitoring for the conveying of how someone is doing at a distance? We also look at what types of health services are being offered. Are we talking about screening, medical advice, direct patient care visits? And then what of those services require new contracts with vendors or outsourcing of services to, say, a third-party group of practitioners who can be providing care 24/7? Next slide. We also ask people to think about where people are in this equation. Where are the healthcare workers providing that service and where are the families? We've seen telehealth delivery models that have both providers and patients in a clinical environment with ePPE. We also have situations where that telehealth care provision is reaching families in their homes or in remote sites. There could be a call center model where information is being aggregated to a central location. There's also potential roles for public health offices in these models. Keeping track of when the services started and when they're being offered. Are these services that are being available during limited hours? Are they available 24/7? And I think when we're in the context of emergency care, the 24/7 model makes the most sense. But for other environments, there might be more of a 9-to-5 service. And then thinking about why is that telehealth service being offered? What was the intended goal? Is it set up in order to try to mitigate spread of disease? Is it set up to try to increase access when services are otherwise being restricted? Is it designed to protect the patients and their families when we have children with special healthcare needs, that if their parents become ill, then the child would be at risk of having a gap in service? And just thinking about that underlying rationale for why the service is being offered. Then how is the service being paid for? What is the role of insurance coverage, co-pays, private pay, out-of-pocket arrangements for this service, and how does that translate into access for people? And then to have people take a step back and think about the translation research and implementation science models that are being applied to this new care delivery system. So those are kind of very quickly our 10 key questions that we are encouraging folks to be asking as they're looking at implementation of new telehealth services or are evaluating longstanding telehealth services. And then the next slide is a preview to the strategies for evaluating telehealth in the STEM framework, which is pre-published at Pediatrics and coming out later this month officially there. So that is a preview of things to come.
Thanks so much for sharing that. And many of those questions that were developed through Sprout will really help us as we begin to think about the development of the environmental scan, specifically for states that are engaged in this telehealth collaborative. Of course, the focus is really going to be specific to emergency care and the emergency care space. So really beginning to think about that, and we'll talk more as we move forward. So thanks for your time. And then Dr. Higa.
Thank you. Good morning, good afternoon, everyone. So I was asked to give a really short 5-minute overview of the Telehealth National Consortium of Telehealth Resource Centers, and also a little bit information about the Pacific Islands region that the Pacific Basin Telehealth Research Center serves. So next slide, please. We are 14 HRSA-funded telehealth resource centers, and we are funded through the Office for the Advancement of Telehealth. And I wanted to acknowledge that our Director of O, Michael McNeely, is a member of this working group. We have 2 national centers, one that's focused on policy and the other that's focused on technology. There are 12 regional resource centers that we provide technical assistance for very tailored, specific technical assistance for our individual regions. Wanted to note that we do not provide direct clinical services and we do not conduct research. But all of the research centers across the country on initiatives where there's need and overlap. So we communicate on a regular basis. We share information across the board on leveraging best practices, contacts, resources, all across the country. And we also have various working groups. So as an example, I'm currently serving on a digital equity working group that's looking at broadband opportunities for even patient families and not just the clinics. And also another working group is developing toolkits, telehealth toolkits for the FQHCs, for example. We do a lot of work together, but we also do a significant part of our work that's really tailored to our local communities. So there's a lot of similarities, but as you can imagine, there's so much differences and uniqueness in our region. And I think that will show a little bit as I talk about the region that we serve in the Pacific Islands. Next slide. Before I do that, I wanted to talk about some of the national resources. So this is the website for our policy, TRC, Center for Connected Health Policy in California, and May Kwong is the executive director. So our policy TRC provides a 50-state telehealth policy report that tracks all the telehealth legislation across all states. Lately, it has been a really key resource for tracking the rapidly changing telehealth policies during COVID and public health emergencies. Next slide. The other National Resource Center that's focused on technology is operated through the Telehealth Technology Assessment Center, or TTAC, in Alaska, and they provide unbiased reviews of technologies and TA. This is one of the new assessments that is quite popular, where they evaluated various video platforms that's used for telehealth. And you may also know TTAC for their technology roadshows, where they bring clinical and communication technologies to conferences and meetings for hands-on demonstrations. Next slide. Finally, this is our consortium website, where you can find your regional TRC's website and a lot of other information and resources, including telehealth toolkits, informational flyers, handouts, sample forms. We also list a calendar of events of upcoming webinars, which I'm sure a lot of you have been featured in some of our webinars. And also you can find past recordings and webinars and PowerPoint presentations. They're all on this website. Next slide. So I just wanted to take the last few minutes that I have to share a little bit about the region that we serve. PBTRC serves the state of Hawaii and the Pacific Islands region. And this is the Pacific Islands on a world map. And if you can find that little speck in the middle of the Pacific Ocean, that's where I am right now, on the island of Oahu in Honolulu. But you can't see the rest of the region that we serve. So to do that, we'll go to the next slide to zoom in. And I just wanted to show you the geographic coverage area is really larger than the size of US mainland. We call it the US continental. But in that Pacific Island region, there's less than 500,000 people that we serve, 480,000 people. Hawaii has 1.4 million, but the whole other regions that we serve is less than 1 million total. So our region serves the state of Hawaii, but 3 Pacific Island territories, and you can see in blue, and then 3 Pacific Island countries that have a compact with the US. Next slide. So I really wanted to just share that, these islands are very rich in natural resources, strong source of sense of community, strong social capital. But as we're talking about QI measures and standards, we really wanted to just emphasize, as in your region, there's a lot of variation. And so there's systemic challenges and development issues in terms of the tiny populations across large areas, the poor economies of scale. This region has some of the highest non-communicable disease-related deaths and the highest, we're talking about telecommunications, it has the highest cost of broadband in the world. And so I wanted to say, though, that this leaves us with tremendous opportunity. So on a bright note, there are pockets in the islands that are using the broadband access to fiber and satellite communications that have shown really good use of telehealth to support our healthcare providers and families and patients in these rural areas. And just like you know, that serve rural communities that are not only very isolated and severely under-resourced, we also have many different languages, cultures, and policies. So to add to the complexity of our region, I just wanted to share developing collectively QI measures that we take into consideration some of the very unique challenges across our country. And I'm just thank you for giving me the opportunity to highlight some of those challenges in the Pacific. So with the last slide, I just wanted to thank you for allowing me to share some information about the resource centers, but also I really appreciate the time given so that I can explain some of the unique challenges in the Pacific. So I really look forward to working with all of you, and mahalo. Thank you, and thank you for your time.
Thank you so much. And I know these were extremely short overviews of really, you know, tremendous efforts that are underway, and it really doesn't give, you know, full kind of credence to the work that they've been doing, which, you know, is just incredible. And fortunately, though, we still have you engaged in the breakout sessions, and there's more to be gleaned and more to learn. And those of you, obviously many, who didn't get to share your work today, like I said, we will be reaching out, because I think it's really important to better understand the immense amount of work efforts underway to support these populations. So we will be moving into the breakout sessions in just a few minutes, and we just wanted to kind of give you a little bit of a framework for what we're going to be talking about today. And, you know, you heard a little bit about the deliverables that we have as part of this advisory council, the first of which is to really support our states to dive deeper and understand the challenges and resources that might be available to support the development of telehealth programs. So that's really where the environmental scan comes into play. And we know that they'll all be doing a certain degree of work as they submit their applications, but how we can support them to really dive a little bit deeper. So if you go to the next slide, please, John. Just to kind of frame this, and we've talked a little bit about this in the past during the orientation session, but the fact that the real focus here is on increasing access to emergency care. And there are a number of potential access points for reaching emergency care. And so I just want to kind of create this visual framework for what we think of when we're thinking of ways to access emergency care. So that might be through a primary care provider, the medical home. It may be directly, you know, through the emergency department or through calling 911 and EMS. It may be alternative acute care sites like urgent cares, minute clinics, and the like. Or it could be through some referral for a subspecialty healthcare provider. You know, in some of our early internal discussions, you know, could it be through, you know, a shelter, a medical home, a rehab facility, and the like. So there may be multiple ways in which a child or family would access emergency care. And I just wanted to create kind of that framework for what we're thinking about as we lead into these breakout sessions. The other piece is to really think about what emergency care is. And all of you are very aware of this. But just to kind of create that visual as well, is that we're not just talking about stabilization and treatment, but also the triage process, potentially assessment, monitoring, consultation, care coordination, education, and the like. And so how can telehealth be used to support various aspects of emergency care? Maybe some, maybe not all, for certain populations, certain communities, or certain jurisdictions, but at least begin thinking about what. John, if you'll move to the next slide. So we do have, we shared with you all last time at the orientation session that there are essentially 9 core areas of focus, and we're going to begin to address some of those today in the breakout sessions. So we've divided the breakout groups into 3 groups that we shared last time. So one, really focusing on children and youth with special healthcare needs. A second focused really on children with behavioral health emergencies. And a third focused on the modalities of telehealth, just more broadly. And the hope is that in each of those clinical breakouts, we can really dive into common challenges and needs facing those populations, and especially looking at the impact that's been had secondary to public health crises like COVID, and what we know may be coming down the road as we enter the winter season with the co-occurrence of multiple viruses. Also looking at resources, you just heard about some of those, whether that be critical crossroads and the like, and looking at who is the workforce that we would want to engage to support these particular populations. In the telehealth group, the focus is a little bit different. It's a little bit more broad. What are the potential uses of telehealth to meet emergency care needs? What are the infrastructure and regulatory requirements that exist to either support or potentially cause challenges? And then how would we go about training and supporting the specific workforce to address these two very specific populations? And we had addressed at the last time that there are some other areas that we will be focusing on, so in future sessions, so certainly developing performance metrics, and also looking at implementation strategies. Those will be to come. What we hope to glean today is really a brainstorming session. And then as we move into November, we'll help to refine those challenges, needs, and scope, and begin to develop some questions that can be used for the environmental scan. I know there are a couple questions that just popped up in the chat box, so I just want to try to address those. So one is, would you consider the home as another access point, particularly for those children with medical complexity who receive home nursing care? Absolutely. I think that is 100% a potential access, and I think that was in part what was meant by just going directly to emergency department 911 EMS, but it could be that that emergency care is provided within the home as well. So thanks for that question. So if you go to the next slide, please, John. So these are just some basic logistics around the breakout sessions. We wish we could all be in person, but of course that's not possible. So we do have approximately an hour that we can spend in the breakout sessions. And I know that may sound like a lot of time, but what we think about what we're trying to cover, this is going to go pretty rapidly. Because we want to make sure that everybody has an opportunity to speak, we're trying to adhere to somewhat of a round robin approach where everyone will have an opportunity to kind of walk through some suggested responses or comments or perspectives. And then hopefully we'll be able to come back around where we can join together and hear some more open discussion. As I mentioned, this will be used to develop that environmental scan, and we'll be sharing reports actually in the November session. Today, we really just want to focus on some brainstorming efforts and really all kind of getting to know our group and getting a feel of what exists within this particular space. And then in our November session, we'll be able to refine some of our thoughts and then really help to drive that environmental scan. So are there any questions before we jump into the breakout sessions? And you'll see your name listed here. We tried to make these all in alphabetical order. I think they are, but if for any reason they're not, apologies for that. But you should see your name there. And just before we break out, Louis and Lisa, are there any names for whom we don't have their breakout session assigned?
No, we are all set.
Okay. Okay, perfect. So Louis, can you give us just a brief overview of what's going to happen next as we jump into the breakout sessions?
Sure. As soon as we begin the breakout sessions, then each of you on your screen will see, you really won't have to do anything unless you're asked to accept joining that particular breakout room. You will be automatically placed into your assigned room. We've already assigned you, so you really don't need to make any decisions on that part. And you'll be in that room with your particular group, and your leader of your particular group will take it from there. And at the end of 60 minutes, you'll see a timer on your screen that will give you another 60 seconds to wrap things up, and then everyone will automatically be moved back into the main session. That's it.
Okay, any questions? Okay, I think we're ready to go.
All right, here we go. Okay, Lisa.
It's just us.
It looks like it's just us, so that's a good thing. That means everyone's assigned.
That means it works.
There, I mean, Ryan dropped off, and so did T right at the end there. She dropped off, so she's not in that group, which is fine. That
Okay.
group, which telehealth was large, it had 12.
Yep.
So now it has 11. Behavioral health, I think, has 9, and the other one is 10, I believe.
I sent Kate a message and let her know who was absent.
Okay.
It actually all kind of worked out. It made them
Yeah.
all about, at least it was well spread across all the groups.
Yeah. Yep.
So now
Yeah, it
we
was
just
really-
wait.
Yeah. Now you can
Okay.
join a group and listen in. So if you see on the screen where you see do you see on your screen the breakout rooms and the in progress and the
Nope.
timer?
Nope, I don't get that since I'm a co-host, which is
Okay.
okay. I have stuff I can sit here and do.
Okay, yeah, that's right. Let's see here. Yeah, it's strange. I guess the co-host, you can't do anything with the breakout rooms. You can with the polling.
You
but
know
not
what
the
I'm
breakout.
wondering about right now?
Mhm.
Recording.
I thought of that about 20 minutes ago, but it was too late. And it was never brought up, so I never even thought about it. Because what I do for each of these meetings is I put a list of everything I'm supposed to be doing, and it was never brought up, so I just missed it.
Well, I was charged to record the main meeting, which I'm doing,
Oh, okay.
but I don't think we'll have a capability of recording the
No.
breakout.
No,
You cannot record breakout.
no. And if you're recording the main meeting now, you want to pause that recording.
Looks like everyone made it back. This is good.
We had no choice. We got caught off mid-sentence.
Not that you mind, right? I'm joking. Thank you. Hopefully that was a good session for everyone. And I know we just have a few minutes left. So John, if you want to go to the next slide, and we'll turn it back to you with just some wrap-up pieces. So one of the last things that we really wanted to do is just get your feedback. This is, obviously our first real main session where we've been able to get together in breakout groups for this advisory council. So what we are going to do here in just a couple of minutes is launch an evaluation live. We thought that this was the best way that we can get your honest feedback. Before we close up, we didn't want to send it to you as something in follow-up. So you'll see that pop up on your screen. So please give us your feedback over the next couple minutes. We will be sharing the results. So nobody will be named. It's all anonymous, but we want to see what we can work on and try to be better about this as we move forward. The other piece that we want to mention before we close up is that our next meeting is on November 10th. This is a Tuesday rather than a Wednesday. Remember that November 11th was Veterans Day. We heard from many of our members that that was not an ideal day, of course, as a federal holiday. So we'll be pushing that to the Tuesday beforehand. And we're super excited to have Sabra Ankner, if I'm saying your name right. Sabra, I apologize. Christina Boothby and Beth Doretsky from Family Voices, all giving us some brief overviews of the work that they're doing to initiate telehealth programs, and all of them have received funding through the CARES Act to their relative organizations or specific organizations. So really looking forward to hearing a little bit more about that, and we'll reaching out to others for additional information. So Louis, do you want to go ahead and post the evaluation so we can
Kate, can I just, I I just want to remind our group, we took an option at the beginning to do a deeper dive into a couple of areas and then opted to follow up offline. So for our group, we'll send out those highlighted boxes that need completion offline, and we'll hope to get those back in 10 days.
Great. Okay. So everyone should have received the evaluation, so please go ahead and let us know.
I think we're pretty close to everyone submitting their feedback. We are 24.
And the one thing I will say is that if you do have comments, please go ahead and share those in the chat box. We know that the survey doesn't really allow you to comment directly into it. So if there are comments that you'd like us to share or see, please go ahead and share those in the chat box, either broadly or individually, whatever you feel more comfortable with. We appreciate that. So, okay. So many thanks again to everyone's time today. Hopefully the breakout sessions were more or less useful. We're about to find out and we'll see how to move forward. So, okay, so in terms of the overview, so again, this was really mostly the orientation session that we shared in September. Sounds like the majority felt that was very effective, so great. If there are specific questions or comments that you all have about that or the role, please let us know if there's any outstanding issues. And that session was recorded and you should be able to access that as well on the website. The next question on how effective was the breakout session? It sounds like people enjoyed that, generally speaking. So that's great to hear. And hopefully we'll continue to move forward. How did folks like the round robin? Can you give maybe a thumbs up, thumbs down in terms of your reaction to that? The round robin, okay? Thumbs up, okay. Okay, great. The next piece is were the deliverables clearly defined?